Thank you very much. We're now going to move to item 5, which is on primary care co-commissioning. We have a paper from Ian, and I will invite you, Ian, please, to introduce it for us.
Thank you. The programme is on track in line with the paper that the board considered in October. This programme of delegating primary care commissioning functions to CCGs is an essential part of the New Deal for primary care set out in the forward view. It is also a necessary precursor to developing new integrated models of provision. We need more joined up commissioning in order to unlock more integrated provision, and it is a vote of confidence in clinical commissioning groups. I would like to highlight the joint working that NHS England has undertaken with CCG leaders, and particularly thank NHS clinical commissioners for their help and their constructive challenge, and request that the board authorise the formal delegation.
Thank you, Ian. Before I put that question to the board, let me invite some comments and queries to Ian. David?
Just to say that the commissioning committee has looked at this as well and is content with where we are. Thank you.
Moira?
Can I ask Ian, on a scale from 0 to 10, how confident is he about the management of the conflicts of interest? Not from the point of view, as it were, of you and someone who understands it, but from the test of the person on the Clapham omnibus.
So we are confident that we are putting in place robust arrangements based on the new statutory guidance that was agreed by the Audit and Risk Committee. We have put in place training arrangements for lay members, and we have a set of rules which includes publishing the decisions of the CCG committees, the open invitation to those committees for local health watch members and local authority health and wellbeing boards. And at this stage, we are confident that the arrangements we have devised will be fit for purpose. Clearly, we will need to continue to pay a keen and close interest to the practical operation of these arrangements once they go live.
Thank you. Ed?
I would just add to what Ian said. I mean, we have been through this in the audit committee. We've also had 2 sessions with 70% of the CCG audit chairs in February. I can't say it's been easy to focus minds on this, but I think all the mechanisms that need to be in place, barring actual working of it in the system, are now in place. The proof will be when the chairs of audit committees have to give the assurance at the CCG level of compliance with the guidance and the requirements, and that's always a test. But I think we have to recognise that we're in that type of system where we are not directly responsible for that. And there's been a lot of encouraging support from the lay members of CCGs about their role in that. Notwithstanding, I think it's fair to say they themselves are under pressure of time and volume of work that they have to do.
I think also it's important to remember the reach of NHS England in our local teams, and what a close relationship many of our local teams have with a small number of CCGs. And so whilst this process has been managed within a national framework, the key work has been done on the ground, where our local teams have actually worked with every individual CCG, going through their application, understanding the workings within the CCG, and only giving us the confidence at national level to support the CCGs that we're going forward, that we're requesting now to go forward to delegation, because they have confidence that it is a CCG where they do have the proper governance arrangements, as the local team has seen from the assurance oversight, and that they can be confident that conflicts of interest have been managed properly. And even at national level, when we've had the conversations, I know many have happened at regional and more local level about this, national levels, we've had specific conversations about a couple of CCGs whereby we had to ask the local team to delve more deeply into an issue of conflicts of interest before we made the final decision to recommend this list to you.
I think those assurances are absolutely essential. The critical issue, I think, is communication here, and communication not only through our local operational team, but also nationally. I think the meetings that Ed has been chairing with audit chairs has been opening up a whole array of issues which we're able to provide training, education, but actually fundamentally support. And I think it's the transmission of messages about our expectations of how conflicts of interest might be identified and prevented, and any damage minimised or mitigated, because only if we get that right, only then can CCGs command the confidence of the communities with which they work. So Moira, thank you for raising that. Are there other questions to Ian on this paper? If not, may I ask you then to endorse the proposal in paragraph 8, which is to approve the delegation agreements and to authorise the Chief Financial Officer to execute the new arrangements. Are we content to do that? We are. Thank you very much. The next item on the agenda, item 6, is the new care models programme. An overview of this. Ian, back to you.
Thank you, Chair. And it's with great pleasure that I introduce this item. There's been fantastic interest in the NHS in the new care model programme. As Simon said in his introductory comments, we've had hundreds of applicants right across the country. People are engaging with different partners to think about how they redesign care for their local patients and citizens. And I think going beyond their current institutional boundaries. What's been really exciting and interesting is the extent to which this has meant hospitals talking to GP practices and with social care, with the voluntary sector and with patient groups. Following the 3 days of selection at the shortlisting process at the Oval, the New Care Models Programme Board, which has now been fully constituted and has met twice, and which I co-chair with Adrian Masters at Monitor. This is a joint endeavour across the ALBs and with other national partners. We agreed 29 Vanguard sites and areas to develop the integrated health and care systems of the future. And I think our principles here are very much about how we support those local areas and solve their problems, and I will come back to that. I would particularly like to emphasise, though, what a difficult set of decisions the board had to make, both at the shortlisting stage and then the final decisions. Inevitably, such selection processes can never be perfect, and there will be many of the applicants who can be and will be just as successful and move just as rapidly as the Vanguard sites. And NHS England, Monitor and our partners very strongly encourages all those interested in redesigning care, whether it's to form a multi-specialty community provider, a vertically integrated PACS model, develop better links and care in care homes, or indeed many of the other types of new care models outlined in the forward view, to press on with the same pace that they were intending anyway. And there's a little example of that. I had the pleasure of spending last Friday down in the Kent coast, in South Kent Coastal CCG, talking to local leaders and patients, and I have every confidence that the application put in by that CCG to become an MCP can proceed just as quickly as the neighbouring successful application in Whitstable and Canterbury from the Whitstable Medical Practice. And indeed, South Kent Coastal CCG are intending to do exactly that. I would also like to emphasise the fact that the vanguard won't just be improving care for their local populations. Their significance is far greater than that. And their collective voice will be immensely powerful. It will be immensely powerful, I think, in identifying the practical ambitions and the changes they want to make in terms of involving patients, involving communities, in really redesigning care delivery systems, working through new workforce roles and skill mix, as well as some of the more technical changes that many of them are requesting, whether that's to the way in which we regulate collectively, the way in which contracts work, and payment mechanisms. And we in NHS England are determined with our national partners, including Monitor and the TDA and others, to back the vanguards and to listen to what they're saying they need. And we are currently going through an in-depth process of visiting each of the sites over a 2-day period to identify their aspirations and their needs, and then co-design a national support programme where it will be the vanguards themselves saying to the national partners, we would like you please to solve these problems, and it will then be our responsibility to respond to that with pace and effectively to solve those local problems. And that is our task ahead. We are setting ourselves up to be able to deliver that, and I'm very confident that we will succeed in that endeavour.
Perhaps we might draw you out a bit further on that. I mean, what do you anticipate will be the problems that they will be asking us to solve for?
So a number of the vanguards are saying that they would like some permission to develop new workforce roles that perhaps blend the role of a geriatrician and a GP, or that look differently at the way in which out-of-hospital nursing operates. And they would like support from the Royal Colleges to be able to develop new job descriptions. They would like help in understanding the potential of digital technology to redesign the way in which people access care. They would like help in navigating public procurement arrangements so that they can develop these new models very quickly. They would like help in understanding contractual arrangements. We have said in our criteria that we would expect both MCPs and PACs to be able to hold a larger capitated contract for a wider range of services. They want to understand what the simplest way of blending commissioner responsibilities are and then creating new contracts. And our intention is to design some new model contracts for the sites, as well as then new payment mechanisms. So actually design the capitated sums for those sites so that they're able to then go live. Because some of these problems that they're articulating are common across the different sites, and rather than each of them seeking to secure separate support and develop very similar but marginally different solutions, it will probably make more sense for them to come together as a collective and commission single solutions which they can then choose to use, and indeed those solutions can be made available to the rest of the country at the same time that the vanguards then are using them. And I hope that we will then be in a position where in a year's time, when we look back on what the vanguards will have achieved in their first year, we will not merely get fantastic examples of 29 unique completely contextually specific solutions that are very difficult for the rest of the country to learn from, we will actually be able to point to a number of places that are choosing to do things in a common way.
Thank you. And let me invite discussion from the board. Moira and then Victor.
Thanks, Malcolm. Ian, I was struck yesterday by how many times people at the UK Citizen event talked about our problems with communication and how much we needed to up our game in relation to communication. And you talked quite a lot about participation, in public participation in the design of the vanguards, which is, I'm sure, the best way of communication, but not everyone can be involved. So is your assumption that, in a sense, that each one will be doing its own communication, or is there, again, national support for that communication and engagement? Will they all be different, or will there, again, be the opportunities of learning what works best?
So I think we have to have a communication approach that is both local and national at the same time. So how we support local sites to make sure that they are engaging effectively with their local communities. And I think, again, that's very powerful, particularly if they have common problems. The extent to which it's then the vanguard sites and their local populations demanding changes or help from the national bodies is far more likely to be successful. But then secondly, in terms of national communications, so I'm building within Samantha Jones's team dedicated communication support, working closely with Tim and Tim's team. We are putting resources into making sure that we can provide a very high quality service. That's our ambition for the vanguards, and to communicate not just the work programme but the stories of what's happening in each of these sites, not only so that they can learn from each other, but so the rest of the country can see what's going on.
Victor.
I'm just curious, how are you, it leads on from the last question really, is how are you ensuring that groups outside the NHS system are engaged in the co-design of some of these services? I mean, how are you ensuring that not-for-profit groups, etc., how is that happening?
So, firstly, I would say the forward view itself, we absolutely placed as core design principles in Chapter 2 of the forward view that when we're designing the new care models articulated in Chapter 3, they had to be based on the principles of prevention and community engagement and citizen empowerment. And those themes are themes that we continually emphasise whenever we're discussing new care models with the NHS. Secondly, we have then, in establishing the criteria and designing the approach for expressions of interest, built in a very clear expectation that the people applying will be partnering with other organisations and showing how they will be engaging patients and their local citizens. It is a core design principle, and it is only through really the in-depth work that we are now doing with the sites that we can understand the scale of that, and also what the ambitions are from the Vanguard sites for further support in this area. But I can absolutely assure you, Victor, that this will be a core theme right at the heart of how the Vanguards operate.
So I think unpacking that conversation is fundamental to the replicability of the vanguards, which if we don't achieve that, then we have just achieved very little, I think. And one of the things that we were talking about a bit earlier is the importance of supporting particularly the vanguards, but the NHS as a whole, to learn something from other industries about what you might loosely call market research, i.e. the person as an important point of data in a way in understanding whether or not something has had a useful, positive impact on them. So apart from engagement, perhaps more conventionally understood, deep immersion, deliberative co-production with local communities and patients, we also need to be very, very specific about building and supporting vanguards to build a kind of market research capability or an insight capability which will enable replication. And I think that's been a gap in a way in the story of how the NHS and health and care in general has approached innovation. And I think that's something which we've been working on, but it hopefully will be a new and sort of embedded feature in the way that the Vanguards operate, and does involve us talking to some very, very different people, across the community at large than we perhaps are used to speaking to.
I think that one of the things that's going to be really important here is that when we look at learning, that we can see something that's very simple. Because the essence of all of this is that we're creating bespoke packages where necessary. And that essentially means that there are lots of variations, and we could have an incredibly sort of complex field of choice for those coming afterwards. And we need to make sure that not only are the learnings properly recorded, but there's a simplicity in the message, but also that there isn't a feeling of blame with anything having gone wrong. What went wrong? Co-creation, there's an enormous amount of opportunity for things to go awry, and we need to be very positive about allowing an element of I suppose, error to be corrected en route, and the learning to be properly recorded from that, to give confidence to go forward.
So I think, Margaret, you raise two terribly important points here, one of which is our appetite for the Vanguard to innovate and to try different things. That's their whole point. Now, clearly, whatever they do, we need to make sure that services are safe and effective, but not all of the new approaches will necessarily deliver the quality improvements and the efficiency gains that they're intending, and that's inevitable if people are innovating. So in a way, it will be a sign of success that we have that innovation occur. The second point I think you pick up in your comment there is around the need for excellent evaluation, and for that evaluation not to be something which is separate and happens after the event, but is an integral part of the design and the implementation process. And we are building a new operational research and evaluation function within NHS England rather than something that we're outsourcing. And I've appointed a head of that unit, Charles Tallock, and he will be establishing a team to be able to provide real-time learning and evaluation and develop that methodology with sites. This will comprise both a set of common standard metrics, and those metrics we will co-design with the local sites, but not just a set of outcome metrics. Because if we were simply saying the only thing that matters is the outcome metrics, we wouldn't be having a structured new care model programme. We are placing a bet here that there are certain ways of redesigning care that are likely to be more successful, and that's something that the NHS has responded to very positively. And that means we also need to get inside the black box of, well, what is a successful multi-specialty community provider or vertically integrated system and so on, and understand the logic model of actually what's going on so that we can understand why these models are successful and why they may not be.
Ian, it's very exciting to see these lifting off, and I had the sense of watching rockets lift off. My hope is that these are rockets that are about to put things into orbit that will then become a reference for the rest of the NHS planet. My concern is that they're actually rockets that are prefaced to the New Year's Eve fireworks display, and they make a big bang and then they all fall back to earth again as charred remains, and everyone said, wasn't that fun? So forgive the levity, but you know what I'm saying. Reading your last sentence, it's a beautifully crafted sentence that says we'll build communities of support, share good practice, accelerate the scale of change more broadly, whilst not diluting the focus and thus the impact for patients, which is a bit like reading my horoscope. And so it's a carefully worded phrase that doesn't quite commit us to saying we're going to deploy this more widely than the community of support. And I guess my question is, in addition to that early 360-degree reevaluation and looking towards replicability in communities of support, if I was looking at this in a scientific way, I'd say what I'd really like to do is randomly distribute the ones that work to places that weren't expecting them and say, okay, we'd like now to try this in a new place, not full of enthusiasts who are going to want it to win, and say, will it work in the real NHS where it hasn't got those unrecognised but very critical leaders that make it work in certain places?
Well, thank you very much, John, for your comment. On your first point as to whether or not this is placing things in orbit or merely New Year's Eve, I very much expect the board to hold the executive to account for the fact that we achieved the former rather than the latter. I think the challenge you raise about wider spread is one that we are, I think, deeply mindful of. What's the best way in which we achieve that? And I think there are some learnings here from other programs about what's been most successful and what hasn't. And we will be working specifically with the King's Fund and a number of other national partners to try and make sure that this isn't just about those 29 sites. I would emphasise that for the changes to work, for the Vanguard to be successful, it means engaging deeply and effectively within those sites with individual GPs, with patients, with nurses, and it requires people to choose to change how they are currently delivering care. And that comes as a result of deep partnership working and significant organisational development. And that takes time, and it requires people wanting to change. And so the one caution I have is against saying that becoming an MCP or a PACS is the only solution, and saying that this is now what we are expecting the whole of the NHS to do, or indeed to suggest that we would be mandating that, because it would then cut across the energy that is necessary for change.
Just think about the integration pioneers, which was another portfolio of very similar things, and what have we learned from that experience, and what went well and what didn't, and sometimes some of the support felt like you maybe would have rather just gone on and done it without the support, shall we say. Have we captured that? Have we captured what's worked? Have we shared that? Have we wrapped the comms around it? Because again, that was all part of what that programme was intended to achieve.
Thank you, Karen, for raising that. And the integration pioneers are doing very important work. There are now 25 of them. That we announced a second wave earlier in the year. And indeed, the South Kent Coastal CCG and the MCP proposals in part were born out of the integration pioneer work in Kent. We have had, I think, a very successful one-year-on event with all of the integration pioneers over the last couple of months, and published a report on the achievements of the individual pioneers. There are some, I think, fantastic local examples, some of which are now well known nationally. For example, the work that Kernal CCG has undertaken with Age UK in relation to delivering services differently for frail elderly patients, which has not only been delivering improved outcomes and reduced emergency utilisation, but it's also, interestingly, I think the figures are something like it's either 40 or 25 of the people who received the service are now volunteering with Age UK to be able to deliver the service that they themselves received, in a really fantastic example of sustainability. So there are many fantastic specific examples. What I think we could do better with the integration pioneers is to think about what are those common elements, and indeed it was our learning from the integration pioneers that has informed the design of the new care models programme, and managerially the integration pioneers will be overseen as part of a single integrated portfolio by Samantha Jones. We now have an effective national local pioneer support group which has met on a number of occasions, which is co-chaired by Francis Martin from Worcestershire Integration Pioneers, and we have been prioritising particular issues that the pioneers care about most, of which I would highlight the challenges of navigating through information governance as one, and there was a national information governance summit jointly arranged with the pioneers, the Department of Health and the many other agencies. We had about 50 people in the room on Monday to try and work out what the best solutions are for that. That work is a test of our ability to be able to solve problems for local communities.
Victor, well, a question had formed in my mind, which was, when is, in your mind, when is this, the whole point of doing this is that it's supposed to change business as usual at some point. So I'm just curious about how it's affecting the rest, is it affecting the rest of the system? I guess it's connected in some ways to John Burns' thoughts, which are kind of, if it's going to be sustainable, then what you can't have is this programme doing excellent work, but actually kind of a project which is not impacting on a rapid shift of business as usual. This, at some point, needs to become what we do around here. So I'm just wondering about that and the risk of it becoming almost in competition. You know, we have two systems. We have the data business as usual, and then we have this. And this actually becomes a bit of a pain because of the pressures of day to day. I'm not so sure it's fair to ask you that question, but it springs to mind.
Well, I think it's a fantastic question, and one we need to be very mindful of. I would say that the vanguards aren't just a set of site-specific pieces of work. They're not merely pilots. And I would say that for two reasons. One of which is, in a way, we will be redesigning national rules and policy arrangements through what the vanguards want. So they signify something greater than merely what's happening in their local sites. And then when that work is successful, and I say when rather than if, it will enable other areas to slipstream and take advantage of the changes that the vanguard will help bring about. I think secondly, I would say that they are part of a wider movement. Yeah. I mean, in a way, the Forward View wasn't generated kind of de novo, these ideas. Many of them have been within the NHS and the health and care system for some time. And I was struck, Victor, by the fact that, you know, there are 170 proposals and expressions of interest, and there are many more who didn't express interest in becoming multi-specialty community providers. Now that, I believe, is unthinkable a year ago, certainly 2 years ago. There is a different mood afoot in many, many parts of the country, and an appetite, I would say particularly in general practice, to rethink the model of care delivery. So I'm heartened that we will avoid your two worlds twin track risk.
Yeah, I just wondered when, as the board, we would expect to see signs of life in other areas of our business that this was infecting in some ways. And I'm just curious as to how we're going to do that. It's just, just a thought.
Well, in fact, I was going to ask whether it would be helpful to the executive for the board to have it in mind that we take stock of the progress of the vanguards and at some point have almost a policy push, a policy support for the movement of the vanguard forward. As Ian quite rightly says, there's a difference between pilots and a vanguard, and I assume you chose your words carefully, as you always do, and vanguards expecting something to follow in the wake, in the slipstream, to use your words. And that's something that I think the board needs to get behind. Otherwise, Victor's fears will be realised and you will get the continuing parallel systems.
If I may,
And
Chair.
if so, at what point would you like us to do so?
I think that's a very helpful suggestion, and we will follow that up. I think there's a practical question around the bandwidth of the national organisations to provide intensive support equally to all parts of the country. And one of the reasons why we have only selected 29, and that's quite a lot of sites, is that is at the limit of our ability to do intensive work. There is, I think, a profound design question for us as to how we can then not merely give permission to the rest of the country and make it easier for them to adopt new care models, slipstreaming in the wake or alongside, almost as an unofficial vanguard, alongside the official vanguard. There is also, I think, a very big question around what is the scale of transformational funding that may be required. We need to understand what the double running costs are so that we can calculate what that would look like nationally. And we need to understand also what the wider support would be needed regionally in order to achieve the wider spread, as well as how we can help build quality improvement capabilities within individual institutions.
David?
I think, Margaret, you raised an important point, and I was going to cover this in the oral report later. We thought about this extensively at the Commissioning Committee yesterday. One of the things that we've asked is that we effectively have a list of the top 10 barriers, and that each month we knock off a barrier, and that therefore there is a mechanism by which we both support the executive but also hold them to account. Because the fundamental issue here is how do we take the learnings that we receive from the 29 vanguards, and indeed that we will get from the others who, as Ian says, will be pressing ahead outside of the formal support mechanism, and that rather than have everyone sort of thinking about these things, there are some of these things that nationally we can solve. There's a lot of them that are absolutely local, and we should leave the people best able to make those decisions, i.e. the local people, to take those. But there will be some that we really need to crack on and focus. And they will inevitably be the thorny, difficult ones that we probably have tried to look at in the past and not done a good job of, and will need to be a lot of momentum with our partner bodies, because it's unlikely they will be purely within our remit. And they'll range from technology to workforce to incentives to contracting to all of those things. We need to get them, find a practical way, even to some extent of an interim solution, whilst we think about the proper longer term robust policy solution, and that will be the trade-off. But speed, aggressively attacking the problem and finding solution will be the order of the day.
I see Ian nodding in enthusiastic assent.
Good, because he's doing the work.
That's exactly it. Look, I think we've had a really good discussion of this, but let's be clear, this is an exercise that carries very high risk. And I think its greatest risk is also its greatest strength. What we've done is actually invert the normal model of reform within the NHS. The traditional model is one of central prescription, top-down structural change and equality across the nation. And our biggest risk is that in inverting that, a different set of responsibilities fall on our shoulders. I mean, first of all, I think the model that you've adopted of running a competition and having it peer reviewed by others in the same competition was really quite innovative and outstanding, and again, a departure from the norm. I think secondly, the model in which the successful vanguards then commission us to do stuff, is an inversion of the normal model, and again, highly innovative. Innovation carries risks, and I think the big risks are those which have been identified by colleagues around the table, which actually go to our ability to satisfy the expectations that we've created amongst the vanguard sites. I think thirdly, the replicability and the slipstream. Gosh, there have been so many metaphors this morning. I prefer the slipstream rather than the exploding skyrocket metaphor. Actually imposes upon us a long-term requirement to be true to what we've committed to. But look, just put this into the context. It was only last October that we came forward with the 5-year forward view. We announced what we were doing. It's now March. We've made, I think, significant progress. What we're going to want to hold you to account for, Ian, I think, is regular update on progress, metrics that we can understand what is happening with the vanguards, but also to the extent that we can assess it. What is the impact elsewhere? What is the impact on those that aren't vanguards but are nonetheless coming in behind the mood of change? Given that this is not something that is being determined by us or by government, but is very much attuned to the enthusiasm of clinicians and others who want to improve the quality of the offer to patients in their area. I think the final issue, and Victor, I think, has stressed it very well, is let nobody be left behind. There is an issue where, and this is one of the great risks, if you're not going to prescribe something top-down, then if it's determined by the pace of change and enthusiasm in local areas, you do get a differentiated effect. And we have always to worry that this should not increase the gap of health inequalities, rather that it should have the effect of reducing it. So those are simply a few of the criteria by which we would seek to assess progress with the project.
May I, Chair, just very briefly, one last comment, which is that the national uniform approach has not solved the problems that we face in terms of health inequalities. In order to fix health inequalities, we need to take a more differentiated approach in local communities. And so I profoundly believe that actually taking the vanguard approach, and actually many of the sites are in deprived communities where the health gap is greatest, is more likely as a strategy to work than having a single uniform approach.
No, I think we completely agree. I don't think anyone around the table believes that top-down uniform approaches are the answer to any of the problems that we've presently got. Good. Okay, well, thank you very much. And please, will you convey to your team our expression of really admiration for what's being achieved and our expectation that that will be continued. Good. Thanks a lot.